I'd like to welcome everyone to the Buncke Clinic Virtual Visiting Professor Series. I am delighted tonight to welcome a very dear friend of ours here at the clinic, Dr. Mike Zenn, president of Zenn Plastic Surgery and adjunct faculty at the University of North Carolina, Chapel Hill. This is a bit of a bittersweet lecture because we actually were supposed to host Dr. Zenn in person here at the Buncke Clinic back in May. And we had everything planned out. Rudy Bunke, my partner, and I, along with Dr. Greg Buncke and all of our partners, had dinners planned and everything, but unfortunately, we all know what happened. And I assured Dr. Zenn that tonight's lecture is certainly not in the place of an in-person visit. It's just going to be in addition to. So we are greatly looking forward to having Dr. Zenn visit us in person, hopefully soon. By way of a very brief background, Dr. Zenn obtained his BA from the University of Pennsylvania, followed by his MD at Cornell University Medical College. Somewhat more recently, he obtained his MBA from Duke at the Fuqua School of Business. His general surgery training was at the New York Hospital, Cornell Medical Center in New York, followed by plastic surgery at MGH and in Boston, and followed by microsurgery at Memorial Sloan Kettering Cancer Center in New York City. As we know, Dr. Zenn spent many years at Duke University. He was professor of surgery and plastic surgery there. He was also vice chief of the division of plastic surgery there from 2009 to 2016. He was also program director in the division of plastic surgery for both the integrated and the independent track. He ran the Duke flap course along with Scott Levin for many years at Duke, and more recently he has been the co-director of the Penn flap course, and I've had the privilege, along with Rudy Bunke, my partner, of going there last year, which was a tremendous time. Dr. Zenn is very, very heavily involved in most of our national societies in our field, has committee memberships in ASRM, ASPS, and the Plastic Surgery Foundation. He's been involved in ACGME, the association, ACAPS, the American Board of Plastic Surgery, as well as WSRM. So really someone who has dedicated much of his time in leadership positions in the premier societies within our field. And I think perhaps kind of most enjoyably, he is really the man responsible for, I think, one of the highlights, if not the highlight, of the ASRM meeting every year, which is the best case, best save competition. This is by far the best attended session, and it really showcases some of the talents of our members. And I think Dr. Zenn is the person that we have to thank for that. Mike, thank you so much for being with us. It's really an honor to have you. And again, we can't wait to have you here in person. But I think in the meantime, we decided that it's nice to have you virtually at least.
Me too. Thank you so much.
All right, I'm going to make you presenter now, and then you should be able to share your desktop with us.
Well, I can't tell you how honored I am. And that was a beautiful introduction. My mom would be so proud to hear all that. I may have to have her watch the virtual replay of that. But no, so honestly, and in all seriousness, we're a small knit community in microsurgery, and what we do is super special. And when you asked me to give a lecture, thinking about what message I'd want to give to the fellows and the residents and those who are coming up in the field, I thought of this title, One-Offs in Microsurgery, and One-Offs in the Joy of Microsurgery, because I think it was very typical of my career in microsurgery, and I think it may be very typical of many careers. Although I don't really have any disclosures for this talk, I feel like that I have dedicated my life to education and educating those in the field of reconstructive surgery through textbooks, apps, online presence, doing videos, and also still working with some companies, working with ICG and visualization for perforator flaps, and working with companies for ADM. So still feel like I have my hand in reconstruction and teaching, and it's amazing how these types of virtual events and streaming things on video have really become the way that our students learn, and they're really lucky. You know, this education is hard to come by in the old school of sitting back with 3 or 4 attendings, and that's all you ever did, and that's all you ever read. So I liked your introduction of where I was. I throw this out as though it's interesting to see how people change during their years after my general surgery training, which is 5 years. My sort of 30-year journey in plastic surgery started off at the Mass General Hospital. which was an incredible experience. There were only two residents per year, and your first year you worked with all the greats, the big names in plastic surgery, and your second year you were on your own and had your own service. And it was real crucible. You were thrown in with really difficult cases and really had to try to figure things out. So that was phenomenal. But I think it was the era of microsurgery where kind of like just getting a piece of tissue to survive in an area where we were doing reconstruction was all that really mattered. And all that was a successful case. It wasn't until I went to Sloan Kettering and I did the microsurgery fellowship with David Hidalgo that I saw what really the artistry of plastic surgery is all about. For those of you who don't know David, he is not only a phenomenal microsurgeon, he is a phenomenal artist as well. And in fact, probably the reason that I went into plastic surgery was thanks to David. As part of our general surgery, we would rotate across the street to Sloan Kettering and doing a month on the microsurgery service, and just seeing the first free fibula flap and seeing him spend countless hours, but forming a beautiful jaw and rebuilding a jaw from a free fibula just blew me away, and I was hooked. So my first job after fellowship was at UNC in Chapel Hill. And it was probably an ideal place for a person to start. They had one plastic surgeon. His name was Jerry Sloan. All he did was kids. There was nobody doing really anything. There was nobody doing microsurgery. And so I literally got to do everything. GYN cases, head and neck, orthopedics, you name it, everything we do in plastic surgery. I had a pretty active hand practice at that point also. And life was good. You can almost see from the pictures, if you look at me at Mass General and Sloan Kettering, thin, gaunt, tired. And then suddenly at UNC, I kind of just like exploded. All that good North Carolina food and, getting a little more sleep, but working hard. And I was at UNC for about 4.5 years, and then was recruited over to Duke by a fellow named Scott Levin, who you all know. And Scott was probably my most important mentor and dear friend in plastic surgery. Scott is one of the most motivational people you'll ever meet, and really got me on track academically and also doing just amazing cases. And as Bob alluded to, we did some really great things together, starting the Duke Flop course together, which was just a phenomenal experience. And all the other things that we did in running the human tissue lab and training residents. So that's been sort of my 25 to 30 years in academics. And one of the things I think that sort of typified my career was that I was doing so many different things, and I felt like I was a really good microsurgeon. It's just that I never really accumulated large numbers of cases in any one area. And I would do really cool cases, but you can't get really cool cases published. And there's like not a lot, a lot of my friends who were doing only deep flaps or only other types of reconstructions were publishing, and I felt I was falling behind a little bit. But like I said, it really kind of typified my career, and it's actually a really fun part of our career. So if we define kind of one-off cases, you think about something that's just really unusual, something really unique, maybe something that you only do once, kind of a one-off. I can tell you that these cases are the ones that push you, and they're really the ones that you never, ever forget. And the other thing that I learned is that everybody loves talking about these cases, because something, we all have these cases that no one really knows about that we do, which brings us to the best case, best save, because in 2006, Scott Levin was the president of ASRM, and he asked me to be the program director. And, looking for something out of the ordinary to do as an event, I thought about my career, and I thought about, we have all these great cases. We should just have like a best case competition and let people kind of show what they have. And I think one of the reasons that it's so popular, and one of the reasons why people really enjoy it, is because this is what we do on a daily basis. We get thrown in a situation. We feel like you have the skills to solve the problem, but what's the answer to the problem? And it really draws on your creativity, and it really draws you out as a plastic surgeon and a microsurgeon to do amazing things. And we're always blown away by these cases because we can imagine being there. And we've been there. And all the sores and all the suffering and everything we put ourselves through sometimes to finish these cases and get them done successfully is just amazing. So that was kind of the basis of this, was kind of like basing it off my career and doing these one-off cases and just sharing them. And of course, we have some distinguished winners. So I would certainly be remiss if I didn't mention that in 2012, Rudy won the best case with one of the most beautiful lip reconstructions I've ever seen using a free innervated gracilis flap. Go figure, who would have known? And just a fantastic case. And then Bobbitt in 2019 with his save of a very difficult penile reconstruction case. And for those of you who have seen these presentations, you know, a lot of it is in the telling. It's the storytelling. But I think that's what we love, you know, telling the stories of our patients and the cases that we do. So this is a talk that's geared toward the fellows in the audience and the residents. And in thinking about this, I was thinking about kind of my own career. And I feel like there are different phases of your career in microsurgery. And once you kind of leave the nest of your fellowship, and these cases seem to go so easily, and you feel like you can do anything, you kind of are thrown into a situation where it's really on you. And it's super critical to get on base and to just solve the problem and not have a problem. My first case in practice at UNC, they had been saving for me, was a really difficult jaw reconstruction that required a full-on Hidalgo mandible reconstruction. And man, like, you don't want that as your first case when you start practice. There's just so much pressure because everybody hears about this guy who's going to come and do these cases, and you don't know who's your friend, who's your enemy, what's going on. And thank God that it worked out, and the case went really well. And I got my first introduction to being in Chapel Hill, North Carolina. I was coming from New York City for my fellowship. And it was 11 o'clock at night. It was a really, really long case. And so the guy who did the resective surgery with me, we said, let's go grab a beer. And everywhere was closed. There was nowhere open in North Carolina, Chapel Hill, North Carolina. And I said, dear God, I have landed on a foreign planet. Because in New York, I'm certainly used to everything being up all night. Getting on base, super important. And really, your emphasis is on the technical aspects of these cases, making sure your pedicle lengths are the right, making sure your flap's the right size, you know, making sure you're getting faster and faster and better at your cases. And I think the critical thing in the first few years is to really do as many cases as you can. And, you know, it is different than when you're in your fellowship. And you really start to become comfortable with being in a situation where something unexpected happens, or the flap isn't what you thought it would be, or happens frequently, especially in head and neck cases, where you had your plan, you knew exactly what you're going to do, and you go in and they end up resecting a whole lot more, or your flap has some variant of anatomy and you can't use it or something. And all of us experienced microsurgeons actually feel really comfortable with that. But it takes a while. And I would say it took me a solid 10 years before I was never worried walking into any case, even cases that I hadn't done before, because I knew I would be able to figure it out. And it didn't mean that all my flaps survived. It didn't mean that when I did a take back that we weren't always able to save the flap. But I was always super positive about it. I think it's because those first formative years. And then after that, I think your focus on the cases changes. So I think when you're confident that the micro is not the issue anymore, it's not about the flaps really surviving. It's about doing the cases. And you've learned so much over that time. I feel like sometimes when you're advanced in microsurgery and you're trying to teach a fellow or a resident who's a beginner, it's kind of hard because a lot of the things that you're doing that make you so much more successful are things that are hard to teach because you can't even put words to them. It's just things you just know by doing it. And sometimes this is why we feel like the most junior faculty sometimes is the best person to teach things to a resident. We say it's because they're close in age, but it's really because it's a different level of learning. The thing that I found most rewarding, though, is that these cases are more than just technical. They're more than just solving the problem. You are actually an artist. There's a very famous saying that these cases, you know, they're not science projects, they're actually art projects. And I think, you know, for a lot of the cases that I was doing in microsurgery, which are facial reconstructions, you know, breast and trunk reconstructions, a lot of it was like the artistry of getting it to look natural and look beautiful, different than some of the other micro, like with hand and other areas. But it's about being an artist. And also what you begin to realize, and this was sort of my pathway into anatomy and teaching more anatomy, doing work with perforators about ICG and looking at blood flow and flaps, is that you realize how unique each person's anatomy is, and that you can write a textbook and tell somebody how to do a flap, but you need to know a lot more than that. And oftentimes that is not really reflected in what you see in your patient in front of you, and that's okay. And you can be very comfortable with that. And what I truly believe is when you find the unexpected, when you do something that's not your normal, I'm just going to do another one of these XYZ. When you actually step out of your comfort zone, do something a little different, that's when you get creative, and that's when something special happens. And that's when you start contributing to the field of microsurgery. And this is a picture of me at one of the flap courses. And I can tell you, first of all, if you have an opportunity to teach a flap course, you should be jumping at it. It's a chance to give back, but also it's a chance, to teach in a very intimate setting. And not everybody gets to do that. But as as a faculty of this course, or any of these courses, you do, and I maybe do the same flap 10 times in a row over 2 days. And it's amazing how none of those flaps are exactly the same. They're all a little different. And, so as go to table 3, they've got great anatomy over there, but it's just the way it is. And you feel comfortable with that over time. So I felt like what would be good to do for this talk would be just to share sort of some of my one-off cases and just talk a little bit about what I learned from each of those cases, because I think cases are interesting. This was one of the first sort of challenging cases I had when I came on board at Duke. They had a very aggressive Mohs surgeon, and it was at the time where Mohs surgery hadn't really taken over a lot of the reconstructive stuff, but we had one guy at Duke who was doing a fair amount. And this lip squamous cell carcinoma obviously ended up being a much larger defect. You can see taking the columella, taking the entire lip, except for maybe commissure on the right. And I think the only reason that we even saw this case is because he ran into the bone in maxilla, and the maxilla was positive. And I guess they hadn't started teaching maxillectomies yet in dermatology school. So referred the patient over to us at the big hospital. And so we had ENT do the maxillectomy, and I did the reconstruction as I had learned at Sloan Kettering, which, was radioform, which I still believe is probably one of the best flaps for lip reconstruction. Here's the design of that flap, shows you how old the case is. It looks kind of bluish, but, on the right side, some tissue for the columella. Never underestimate in the lip how much skin you need, not only to form the outer lip, but then also to form the inner lip. And that's often a miss early on when you're doing these reconstructions, to not realize what you need for the height of the lip, in the middle where the lip would be. And then now that the maxilla is gone, there's a defect in the palate to cover. So here's my reconstruction at the end of the case. You use aesthetic subunits, little cheek advancement to get the scars where you want. This was a free flap that was tunneled down to the facial vessels. And here's his result. And that, this is a very respectable functional result. And, and during my time at Mass General, this would be a slap on the back and move on to the next case. And I think what I learned certainly at Sloan Kettering, and also being influenced by people like Julian Prebace when I was in Boston, people who would always do that little bit more, a little bit tweaks just to get things to look really good. This doesn't look great. And this is something that's going to be super noticeable. I had seen Julian report a case once where he did a scalp flap for a mustache. So I thought, hey, that's a great idea. I should do that. So superficial temporal based flap. What's important in planning is obviously to choose the hair that you want for the mustache, make sure it's obviously going in the right direction. Pedicle length is going to be long enough, and the plan here would be to elevate the flap, make a subcutaneous tunnel, and then to remove that outer skin from the radioforum flap and replace it with the scalp. And in this particular case, as I was elevating the flap, and once I got it down to the pedicle, the flap looked pretty purple. And one of the things I did learn in my very conservative training at Mass General is how to delay things. Don't take chances. As soon as this thing goes under a tunnel and gets kinked, it's going to have even worse blood supply. You're going to be sacrificing your radioforum flap. So I guess another key learning point is don't go ahead and take away your recipient site for the flap until you're sure the flap's going to be okay. So I just put this back up for a couple of days and then brought it back down, and ended up working out really well. I was going to tattoo his lip. I was going to do something for the color on the lip, but one of the things I learned over time doing a lot of head and neck cases is that skin that's by saliva all the time will have a natural pink color. And this is, this is exponentially better than the result that he had. And it becomes very gratifying then. So what did I learn from this case? And so there's more than just to a reconstruction than just making someone functional and moving on. That some of the best things and the fun things that we do are trying to recreate what looks natural and looks normal. And that's the artistic side of our brains, and it's why we became plastic surgeons. And it's not only beneficial for the patient, it actually is beneficial to you too. And expand your skill set as to not just, There's a lip defect, I do a radioform next, but what do I need to do to get this to look really, really good? Certainly, there's time when having hair follicles is a huge problem, especially with head and neck reconstructions, and I've run into many of them. But at a time like this, scalp flap or submental flap or somewhere where you have hair-bearing tissue can actually be really beneficial. And sadly, I've never done another scalp flap to do a mustache reconstruction. So relatively early in my career, this beautiful case, never really had a case to do another one. It seems a little strange. So that's a one-off. This is a 12-year-old boy who had a benign yet aggressive tumor of the nose and had this resected finally by Mohs, and this was his final result. And this is a kid who, at 12 years old, was very similar to my son's age. And I knew how to do this reconstruction. I mean, I had learned from Gary Burgett about aesthetic subunits and how to do a forehead flap. And God, you see his results, and they're just so beautiful. And just the thought of doing a forehead flap in this kid and having the family go through this and then ending up with like this lump on the nose and how many revisions just to get it good. And I can probably never get it as good as Gary. And something very fortuitous happened. So when this case came and we were talking about it, it was also during our 2007 flap course. And the best thing about flap course is you get to hang out with some of the greats, people who you've admired over the years and copy their work and become friends and realize people are just normal people and we all do what we do. And in this field of giants, surprisingly, the person who became significant for me was this gentleman in front, Yixing Zhang. He was from Shanghai, a young plastic surgeon who really nobody knew. He was at Duke doing a one-year fellowship and had just arrived. He had maybe been there a month. And we had been talking about the case, and when he came, he didn't speak a lick of English. And he came up to me and he said, you should think about doing a preauricular flap for this. And then I didn't really know what a preauricular flap was. And I'm saying, well, kind of described it. I said, can you show it to me in the lab? And the best thing about Duke is that we have all these cadavers. And so we went down into the cadaver lab and he showed me how he did preauricular free flaps and said he had done 6 of them and that this might be a really good case for it. And the more I thought about it, the more I thought about having this pedicle and having to divide it and all the other nonsense that goes with forehead flaps, I actually approached the family. And this is what you can also do when you're in that second phase of your career and you're very comfortable in your own skin, is tell them, I have this idea. I have this idea for this flap. I have never done this before, but I think he's a good candidate for it, and I'd like to try it. And had a very honest discussion with the family, and they let the 12-year-old decide, and he was all in. He said, absolutely. And from my standpoint, of course, always thinking what's plan B is like, well, worst comes to worst, I'll do a forehead flap, right? So we went ahead to do the case. And so certainly using all the techniques and thinking that we would use to do any regular nasal reconstruction, base it off the opposite side, get a sense of what the defect is. From the worm's eye view, you get a really good idea of how much lining is missing. And even in forehead flaps, this is where I think we often fall down in our nasal reconstructions, just not having adequate lining, focusing too much on the cover. There's cartilage missing. So again, this is a superficial temporal based flap. And so here's a design, and this is where someone had a eureka moment and looked at this part of the ear and said, this is exactly what we need to reconstruct the nose. Thin layer of skin, cartilage, and now you can do free flaps. There's a blood vessel that runs right through here. It's actually a very easy flap to dissect. Now, Yixing, who is more of a super microsurgeon, bases his flaps mainly off the continuation of the superficial temporal vessels. So he would take a flap from the ipsilateral side and that do as anastomosis to the end of the angular vessels, so below 1 millimeter size vessels. Now, I did microsurgery, but I was not doing any super microsurgery, not in a case like this. So I did a more roundabout technique of taking the vessels more proximally, so they were larger, and then deciding I would just use the facial vessels or the neck vessels and do some sort of loop or graft. And so here's the flap dissected. Like I said, easy dissection. You don't even see the vessels. You keep all the fatty tissue. I've got my superficial temporal vessels. And the other thing that Yixing said is that don't use the saphenous vein or cephalic vein or an AV loop, use an AV graft. And we had been started doing a fair amount of ALT flaps at the time, so I was familiar with the pedicle. I just had never thought of using it as an AV graft. And it made a lot of sense, especially in a young kid. It's going to give half this donor scar. I don't have to make as much scar. The other thing that's nice, as we all know, when you feel comfortable dissecting this flap, easy to find this vessel, not a critical vessel, which is also really important. But if you need a bigger diameter, you just go more proximal, and you can go all the way down as the vessels get smaller and smaller and almost match where you have to reattach your vessels at the superficial temporal area. So, it's a great way to take a graft, went ahead and did that, made a tunnel, connected to the facial vessels, then connected to the flap and did the inset. And so this was the final result on the table. And of course, there's still scars, but at least they're in areas where they're going to be well hidden. Jeff Marcus, who was my partner at the time at Duke, who did beautiful ear reconstructions, helped greatly in this case because I didn't even think for a second about what I was going to need to do about this reconstruction. He took a chondral cartilage graft and then did a little post-auricular, like mastoid-based flap and covered it. And I was thankful for that. And the kid did beautifully. And what I was shocked at, this was a couple weeks after surgery, it was just how beautifully shaped the nose was already. Just knowing what a forehead flap looks like and knowing how many revisions you need to do. Other than, being hidden from the sun and not having a lot of freckles on it, truly amazing. And what I think also is truly amazing is, we have to be really careful about our donor sites. What a beautiful reconstruction of the ear. I think, a lot of the board answers for this would be some sort of anti-Bush, advancement and changing the shape of the ear. But absolutely spectacular. No one could tell that he had surgery. And this is a durable result that actually started to grow as he grew. And this is him at 3 years. Don't see any of the scars anymore. Told him he needs to get out in the sun a little more, get some sun damage to the tip of his nose. But other than that, absolutely a spectacular, one of my most beautiful nasal reconstructions of the nasal tip. I mean, you just don't show worm's eye views when you do forehead flaps for this type of nasal reconstruction because it never looks good. And you say, oh, no one looks up that way anyway. Spectacular. And this is the cool part about being in plastic surgery for a little while is that he actually showed up at my clinic 8 years post-op. So he's gone from a 12-year-old to this 20-year-old giant and looks amazing. Still needs to get more sun to his nose, but the nose grew appropriately with his face, which is kind of cool. And I asked him, how's it been? Is everything okay? And he told me that he's like this huge kickboxer and he gets hit in the nose all the time and hasn't been a problem for him. So very cool to see these types of patients in follow-up. They really are indebted to you for what you've done. And you're indebted to them for the experience of doing the case and having it done successfully. So for this case, what did I learn? You have to be critical. There's getting on base, but if you're not reviewing your cases and looking at your results and saying, God, does that really look as good as it possibly can? Or if you're seeing a Gary Burgett and you're seeing these amazing results, like what do I need to do to get there? Because I can get there. And it's just a matter of putting the energy into it and putting the time into it. There's just so much dogma, and especially coming out of fellowship. I mean, I did everything exactly the way that it was done in fellowship, down to the pull sheet for the cases and how to do everything. It takes a few years to find your own way. And dogma is meant to be changed. So I would encourage you to try to expose yourself to new things and try different approaches. Things can get pretty boring if you're just doing the same thing over and over and over again. And I can tell you, the only way you're going to grow in this specialty is when you stop doing what you do all the time. You step outside your comfort zone and do something that you haven't done, and do something different, and you will grow. Sadly, this was a one-off for me. I have never done another preauricular flap as a free flap. Kind of sad. So, probably as a result of either Yuxing's poor English or my inability to understand what he was saying, he asked if we could write a paper together, and I was excited by that. I had like one case. He's like, oh, it's okay. He has over 60 cases, not 6 cases. So we wrote this article together, 63, one of mine, 62 of his, of nasal reconstruction using this flap. And also mentioned here in the synopsis and in the paper about the lateral femoral circumflex vessels, but that was kind of buried. The story doesn't end here though. So now the next year, 2008, of course, a really cool case. So I'm going to present it at the Duke Flap course. Why not? You know, it's not a flap necessarily that we're teaching, but maybe we should. And of course, cast of characters. And whenever you see pictures like this and you see people sitting in front, they're the ones that kind of want all the attention, but the real microsurgeons are the ones that are all the way in back. This is Julian Prevase. Julian was a regular at the course every other year or so. And Julian, I admired so much when I was at Mass General, and he was at Brigham. And of course, Mass General and the Brigham hated each other. Faculty never talked to each other. It was just this huge, you know, rivalry. But I always admired him, not only for being such a gentleman, for being just a phenomenal plastic surgeon, consummate gentleman, and just everything you'd want to be in a plastic surgeon. And so I presented the case, and afterwards he kind of strolls up to me and says, you know, Mike, that AV graft is actually a flap. And I'm like, you know, Julian's up here somewhere in the stratosphere. I'm like, you know, what the hell is he talking about? And we like start talking about, listen, it's blood flow, there's flow within it, it's alive. And I was like, this is what every graft should be. Why do we have one tube going all the way down to a flap? It has to perfuse, and then one tube going all the way back, when you can actually have flow within the actual vessel supplying blood supply to your flap. And in fact, it changed the way that I dissected my free flaps. You know, I stopped doing extensive separation of the artery and vein. I only separate the artery and vein now to do the vessels that I need to do, because you want that interconnection, because you want blood flow within there. I thought it was a unique idea that a lot of people just didn't know about. There's really nothing in the literature about it. And so I took the opportunity to say, hey, we should write this up. And he had about 20 cases over a 40-year career or so. And it was just such an honor to me to be able to write a paper with a legend and someone who I looked up to so much. But talking about this vessel is just a great idea, and why use an AV loop when you can do this, especially now so many people are doing ALT flaps. So what did I learn? Well, you can milk more than one paper out of a case, you know, and you got to do that early on in your academic careers. You got to start building your CV up. So don't settle for one. Collaboration, you know, you can collaborate with other people who share your ideas. They may have more experience, but it allows you to bring that kind of one-off case into the daylight and a wider audience, so people can see it and learn from it. Certainly to respect and celebrate your elders, as I have gained a lot of gray hair myself now. I insist on this. And but really, like, these are the people who have made it easy for us and made it seem like it's nothing out of the ordinary. And it's our job to push things along. Yes, sadly, this great idea of the AV graft, I only did one more case using it. And, you know, that was over about a 15-year span. So it's not that I didn't want to, it's just whatever cases came along. And when an AV loop was just a better choice for me. So this is a case about planning and then throwing the plan away the minute you walk in the room. And this will happen to you a fair amount. This is a case of chest wall cancer. So this is a woman who had breast cancer on the right. She was treated with a pedicle flap at an outside plastic surgeon, actually from another state. Had radiation, and then a couple years after her radiation had developed this tumor, which was actually a radiation-induced sarcoma. And turns out, especially by the time she got to Duke, this was a very rapidly growing, aggressive tumor, was actually literally growing down the pedicle of the rectus flap itself. So my philosophy on chest wall reconstruction, it's actually very simple. You can take as big a whack as you want out of the chest. There are 3 flaps: rotational latissimus, external oblique flap rotational, and a vertical rectus rotational. You can take any 2 of those flaps and you can close almost anything. And then I've got the pictures to prove it. Huge whacks. So I kind of knew what I was going to do in this case. And so we had the thoracic surgeons. They had some GI surgeons as well. Here's the specimen. The left side of the specimen is the tram flap, that radiated tram flap. We see some of the skin from the belly wall also has been resected. When you flip the specimen over, you get a better appreciation of the entire rib cage has been removed. A large part of the diaphragm has been removed, and certainly a large part of the skin has been removed as well. And this is what you see when you walk in the room. This is a pretty extensive defect. Certainly the entire rib cage on the side has been removed, and we're looking at the lung, which is which is not being ventilated at the time. The diaphragm in this area is completely gone. We're looking at the liver. Large part of the abdominal wall is gone as they chase that muscle down to the belly. So latissimus flap is not available. There is no thoracodorsal system in this patient on this side anymore. External oblique is in the specimen on the back table. Vertical rectus possibly can harvest it. You have another huge hole on the other side. It's not really going to be very helpful. So you need something. And so fortunately at Duke, you work with wonderful interspecialty teams. Our thoracic guys and our GI guys are great. So around this era, everything was Gore-Tex. So they did a Gore-Tex reconstruction of the chest wall, a Gore-Tex reconstruction of the diaphragm, and a Gore-Tex reconstruction of the abdominal wall. So basically we had a huge area of Gore-Tex that just needed vascularized coverage. I just needed the biggest amount of vascularized tissue I could find. And I flipped the patient, took the entire latissimus flap, took the entire serratus flap. Generally, that's more than enough to cover a very large area as a chimeric flap. The advantage, obviously, of having to only do one anastomosis. In this case, it was not enough. Got about 2/3 of the Gore-Tex covered. The entire kind of lower third was not covered. So we opened up Gore-Tex and harvested the omentum, did rotational omentum, and did a little vest over pants type coverage here. So we doubled up the central portion. And then with good vascularized tissue, did the free flap to the IMA, which was still available, was then able to just do a skin graft over this area. So a really hard, difficult problem. We were able to use microsurgery to help get out of it with a little help from a rotational flap. And remarkably, this patient did amazing. Never turned a hair, never had exposed Gore-Tex, never had issues with hernia. And it's just an unbelievable result that we worried about a lot and thinking, okay, what are we going to do when the flap fails, or which has got a hernia now, or when there's Gore-Tex exposed? And fortunately, never had to do anything. So what did I learn in this case? You know, you can say you expect to always expect the unexpected, but man, sometimes you're really just going to be shocked. And I learned this lesson probably most in head and neck surgery, where I never ever actually started the flap until they had done their resection, because you would never know what these guys were going to do. You can't really solve everything with one flap. I think there is this feeling like if I could find that one flap to do everything, and I've done pretty big scapular flaps and flaps to try to do everything with one flap, but sometimes you'll have a better result with two. Sometimes 2 flaps aren't enough, and this is a great example of that. Having a great team, obviously, to make something like this successful, you know, not even having to focus on the hernia aspect, the diaphragm, the chest wall, and getting great post-op care in a thoracic ICU. And, you know, what we do is artistic, what we do is functional, but we also do things that save lives. And it's a really good feeling if you are allowing your oncologic surgeon to really have at it and do what they want. And don't worry, we'll figure out how to take care of getting things closed. Sadly, I've never done another case where I've needed 3 flaps in one surgery to do a reconstruction. So, and that's kind of a good thing. Don't necessarily want a lot of those cases. Some cases you get a little more attached to. This kid came to me after a couple years of his Romberg's hemifacial atrophy, had finally burned out. Now a 16-year-old kid. And you know how tough that can be at that age, and just how, you know, he was becoming a social recluse just because of people making fun of him. Fat grafting really wasn't as established at the time. You know, I feel like I'm pretty good at fat grafting now. This is something where fat grafting probably isn't enough. Someone tried it and nothing worked. So they sent him to Duke and to me for a free flap. Having trained in the New York area, being influenced by John Siebert, who had an incredibly large series of doing scapular free flaps for this. This is kind of the flap I chose to do. Sort of my plan here of what needs to be done, where the skin will sit, where the fascial extensions will sit. If you haven't had the opportunity to do many scapular flaps, this is an amazing flap. Given the obesity of the Americans, and this is an area where often flaps are super thin, it's just an easy flap to dissect too. It's just really hard to screw it up, to finding the triangular space, and you're there. And so it's a fast dissection. The problem is it's on the back, which is not super convenient. For head and neck, it actually can be, because I can do the entire case in a lateral. And so you can do your flap and get your vessels ready and do the flap and close and do everything together. So That's what we did for this case. My little template from my green towel, some Doppler signals where the circumflex vessel is, harvesting the flap. Now he almost looks like he needs bone. There's so much volume that's missing there, and doing something more than just fat. So back's got this nice thick dermis as well, which is why I think John Seaver liked it so much. You can also do fascial extensions. Nowadays, I think I would do more fat grafting probably in addition to this. This is like a nice matrix for that. But the goal was to get this to do most of the work. This is a free flap that's attached to the facial vessels. This is him 2 months after his procedure. And I was kind of proud of this case. He was much happier. Definitely felt like the left side was maybe a little bigger still. Certainly had something going on under the eyes and pulling down to the eye, where that was probably a lack of just supportive tissue. Did do one small touch up for him about a year after the surgery, some liposuction, and did a little bit of fat grafting. Don't really know how much it helped. He pretty much disappeared after that, although he did contact me about 3 years later. He was in Chicago starting a family. I asked him to send me some pictures. And so the pictures are kind of dark, but I was pretty impressed how things had held up over time. This is now 3 years out. Certainly things that I would want to touch up, but he wasn't in the area and wasn't really interested in having more surgery. And wouldn't you know it, this year calls the office, finds me. I'm out of Duke. He's got some questions for me, something about hardware, this or that. And I'm like, just curious. I got to know what he looks like. I got to know. And it's like, can you just send me some pictures? Do you mind just sending a picture of yourself? And so I took this picture on his phone, and I just like had this moment where I just felt so good that, wow, this has turned out amazing for this kid. And I had felt so badly for him when he was a 16-year-old. And now almost 10 years later, he's got a family. It looks pretty good. And I was like, this is an amazing case. And this is sometimes the issue with plastic surgery, is that we have such delayed gratification. We had a big practice in facial reanimation, putting flaps up, and then you're kind of waiting to see what the result is, and for this, to get satisfaction almost 10 years later was kind of cool. So what did I learn in this case is that, it's all about how it looks. And a lot of what we do, we talk about replacing like with like. It almost goes back to the whole argument of, should you do esophageal reconstruction with jejunum, which is like tissue, or should you do an ALT because the voice is better, and it's that kind of discussion. But you shouldn't necessarily, close yourself off to other ideas, especially if it's not like tissue. And, the biggest bugaboo in plastic surgery is that we're artists, but the medium we're working with is tissue, and scar tissue ages over time. You don't know what you are going to get from swelling over time and scarring, and you're not going to know how things age over time. And I would venture to guess that that photograph that he sent me was probably taken at a sort of pinnacle, the best time that this was ever going to look, and he looked amazing. And I almost guarantee you, if we get a picture of him 10 years from now, things are going to have changed. It's completely different on each side. And, and that's just the way it is, so a lot of times you're looking at photographs or pictures of people who are doing reconstructive surgeries or things, and they look amazing, but like they're still post-op swelling, or they're a year out, or they're 10 years out and the scars have faded and they've gained weight and all these other things have happened. So I appreciate that. I am sad to say that I had never done another scapular flap for Romberg's disease after that case. And I kind of, in putting this together, kind of chuckled to myself, because it's like, man, when you only do one of something and it turns out, you seem like the smartest guy. I'd be like, man, that guy Zenn, he's like great at Romberg's cases, And man, if you started doing 10 of those or 20 of those, I think you would be learning a lot more, and you'd be a lot more humbled. But these are one-offs, right? So I share it with you. Speaking of emotional attachments, this is a guy who I think I saw a lot of these cases when I was at Duke, because they had a very aggressive thoracic service. He had had a squamous cell, radiation, recurrence. So he had part of his lung removed, had this closed space abscess, then this closed space wound. And these are the type of cases where patients will have a pneumonectomy, and the thoracic service will send you the case. And they'll say, "I'll just do some free flaps and fill this hole up." And it's this cavernous. It's like it's the entire hemithorax. Like there are no flaps that do that. And they're really hard cases because they're so heavily irradiated, and especially something like this where it's like it's in the middle of the back. Like there's no latissimus to just flip into here. And this is tissue, and you've all experienced this. This stuff is rock hard radiated tissue. And you can see from the ruler, it's like 11 centimeters deep. And so these are cases generally that get sent out with bag of dressings, and things will heal over time, or the patients will pass or something. But this guy, there's something about this guy resonated with me. We were exactly the same age. And, he was very, very much athletic before all this happened to him. He loved scuba diving. He loved being out on the beach. And this particular wound just prevented him from doing the things that he loved so much. And the other thing that was heart-wrenching for me was his beautiful wife. And we became friends over time. But when I met him, that it was her responsibility to take care of this. And this thing smelled, and she had to change the dressings multiple times a day. And I'm like, we need to figure out something. And so I couldn't use anything local for him. And I said, I'm going to do a free flap for this guy, and I'm going to try to fill this with some vascularized tissue. I'm going to try to get this thing to heal. So my plan for him was to go to the other side where the latissimus was available, because again, I need a whole bunch of tissue. The latissimus is a big flap. And I'll plan it in a way that I can, after I do my anastomosis, I can duct most of the muscle in, and I'll still have a little skin paddle to help close the skin in this area here. Rather than trying a skin graft or something like that. The problem, of course, is where are you going to do your vessels to? Axle is not really that comfortable for me in this type of case, going through all that radiated tissue. What I opted to do for him was to do an AV loop from anterior neck, where I was comfortable with the vessels, and ended up hooking up his AV loop to the external carotid and to the EJ, and lay the loop in the neck, and then flip him over and debride the wound and expose and get the loop, and then kind of make a decision. Are we going to go ahead? I always had done AV loops and free flaps right away. I know a lot of people like to let them live for a while so they know that they're intact. But if you're comfortable with the micro, and once you've done micro for a while, I think it's very safe to do that. Opened up, found the loop, it looked perfect, went ahead, dissected the flap, did the microscopic anastomosis, flap looked great, took all this muscle after doing the debridement, stuffed this thing in there, closed the skin, and kept my fingers crossed that everything was going to be okay. Again, worst case scenario, he ends up with a wound that he had already. And, fortunately, he actually did really, really well. Certainly his wife was happy because she no longer had to do these crazy dressing changes. And after a little adjustment and limiting his activity for a while, making sure that this thing really had grown in well, you can see he started getting in really good shape again. He bulked up quite a bit. Certainly the non-radiated tissue helps that area heal. He was able to get back to what he loved the most. Sent me this picture from Hawaii where he took his family and did scuba diving, and just like one of these really feel good type stories. And I think we had built a special relationship. And it just felt so good to be able to help him. And it's not a case I normally, honestly, would have even tried to tackle. But I think it's just that emotional attachment. And it was super sad to hear about 1.5 years later that he had passed from recurrent disease. But super, super nice guy. And I can definitely see myself in him. So in a case like that, what can you possibly learn? Well, our patients are human beings. And I think we can look at pictures and decide what we would do or wouldn't do, but sometimes you extend yourself, and we're human too. And you have to be careful of that, because that emotional attachment can get you into trouble. Certainly we've all seen cases, or maybe personally been involved with cases where we ended up getting into some type of reconstruction that we probably shouldn't have even started. So, there's no question that our specialty, you are doing things that are out there or new, or things maybe just to help people, that you can cause a lot of problems, and patients can be worse off after what we've done. And that's the hardest thing, possibly the most bitter pill you can take. But I tell you again that until you step out of your comfort zone, you're not going to grow. And that's where the magic happens. That's where the amazing things happen. And you discover new things and can share new things. And never needed to do another back reconstruction with a free flap. So it was a one-off for me, and just not a case that we see very much. Honestly, working with Scott Levin, Scott got a lot of these referrals, and for Scott to do a free fibula to the aorta on a case that has instrumentation in the spine was just like a daily case, and my cojones are just not as big as Scott's. So we talked about one-offs. just some fun cases to sort of sink your teeth into. So where's the joy part? Well, you get a certain confidence that you really can do almost anything. You know, you have the tools, and that's amazing to have a job where you can help people, stimulate your mind, and use your hands to go in and actually fix a problem is a really special thing. I've always tell everybody the best part about being a plastic surgeon is living vicariously through our patients. You know, I think we work super, super hard. If you're a microsurgeon, especially if you're at an academic facility, you know, we're just operating all the time, and you gotta really cherish the time that you spend with your patients, because there's a whole life going on out there, and we're giving up some of that by working so hard and committing to ourselves. But if you can have a job like this where you can be creative and you can sort of scratch that itch in your brain and think of something, you know, that someone maybe hasn't done before. Of course, the irony is that almost everything's been done before. You know, it's just that you know about it, so it's kind of like, hey, I thought of it too. But you know, to think of something different, to do different things, and probably the most gratifying is just to be able to teach others, fellows and residents like you know, because someone was kind enough to do that for us, and we are also relying on you to take what we have learned and now in your career advance it and do amazing things. And there's no better joy for us. You know, you have the opportunity to teach. You know, you should jump at it. It's incredibly rewarding, and it's been certainly some of the most satisfying things I've done in my professional career. The other fun part about microsurgery is it is really small, and there is a great camaraderie. This is, and I'm glad Mingwei is here. Mingwei, there you are, my friend. You know, what we all do is very intense. We all do it a little differently in different places, but when we're together, no one can really appreciate each other more than other microsurgeons. And as you can imagine, after a full day of teaching like a Duke flap course, coming to my house for dinner is just an incredible time. A lot of drinking, a lot of tall tales, and just a lot of fun, and all realizing how special how lucky we are to be able to do what we do. So I have a couple of final thoughts for you. I'll play old dad on this. So what's the final thoughts for one-offs? Well, like, you never know it's a one-off, right? I mean, it's just something new. The cool thing about them is that they are really pushing you to think differently, that you're sweating it out, that what you planned on doing failed, and you have to get creative, and good things will come. And you'll know it's a cool one-off when you drive home and to yourself, you're like, holy shit, I can't believe that I just did that. Like, that's so amazing. And you'll go home and like, it's hard to tell your spouse or your kids because they don't really understand that. And then at night, it's really hard to sleep because you're like, okay, like all the bad things that are going to happen now. And because we've lived through all these things, it's like the phone's going to ring and it's going to be, the signal's gone. They're bleeding. I can't get a pinprick out of the flap. You know, you name it, whatever. You can transfer to the ICU with a heart attack. I mean, these are all things that I've seen. It's crazy. And then, of course, you wake up in the morning and there hasn't been a call and you don't even feel like eating breakfast. You actually can get in your car, you get to work, you're going to see that patient, you're going to go in early, and you just have to see for yourself. You see the flap, it's pink, everything looks good, and you're like, okay, I'm going to go get a cup of coffee. Everything's going to be okay. So I'll share some final thoughts on just my career, personally, in microsurgery. What's amazing in a career is just how random, like, the cases that you get to do are. Like, these are one-offs because that second, third, fourth case never came. And in some cases it might be intentional, you're choosing not to do them. In some cases it's just the way that it is because it's where you're located. And what's also amazing is that it could be the beginning of something really cool. And in fact, it could be your thing. You know, your first transgender case, and suddenly, like, you're the person who does most of this and innovates most of this. And so again, stepping out of your comfort zone, doing something different is how these things happen. And I never really think of microsurgery as a case. You know, what you doing today? Oh, I got a micro case. It's not a case. Okay, it's just a tool. And it really becomes like that. It's just your way of getting things done. And the cool thing is that, like, the entire body is now, you know, your sort of plaything. You can take whatever you want from anywhere, as long as you can get it to live, as long as the donor site's okay, and you can do that to do a reconstruction. And that's really, really cool. And if you think all the flaps that have ever been described are done, you're wrong. And if you think about it, and this is what I learned really from studying anatomy and doing a lot of the ICG studies that we did at Duke, is that every case is really a one-off. If you think about it, there's no two cases, no two anatomies that are going to be the same. And when I go in and it's a perforator case, like, to me, it almost doesn't matter that there's a CT angio. I understand the comfort in having it. You know, I know the vessels are there. It's just my job to do a dissection and find them, and you get really good at that. And sometimes you find you don't need technology as much. And think about it, you know, if you had, and you know this is from the different people you work with, that same patient going to any other plastic surgeon, the result's going to be different. And it doesn't mean that one's better than the other. I mean, we can judge as to what's better, what's not better, but they're successful cases. So what you do really is individual, and that case really is a unique case. And the only thing I would urge you is that as you get started and as you're doing these cases, is to really document your cases well and then be critical. Make sure you're reviewing, looking at your cases. And for really cool cases or something you do different, take the time to write stuff down. Keep a little journal, keep a little notebook, because that next case may not be for 4 years or may not be for 7 years. You know, I remember I had to do a trapezius flap, and I was like, God, the last time I did a trapezius flap, I had to pull out my own book and read the chapter because it had been so long. So some final thoughts on your career as fellows residents getting started. Well, you know, from my standpoint and from the teaching staff standpoint, all of you are one-offs. You know, you're all completely different when you show up. You have different education, different experience, different upbringing by your parents. Technical skills are a little different. And, you know, there's never going to be another resident or fellow that's like you. And what you bring to the table is truly unique. And, you know, as a program director for so long at Duke, you know, we would have our meetings and we talk about who's the best resident, who's great, who's not great, and maybe complain about some of the problems we were having. And I'll tell them all the time, it's easy. It's so easy to teach people who are like super skilled and really good. You know, where we have to dig in is for people who are struggling a little bit, because everybody can do this. It's a matter of just really committing to it. And I would tell you, embrace these challenges, these really challenging cases, and don't settle. Seek out excellence. It's okay if you make mistakes. We all have. You know, it just looks like when you're with your faculty at the Buncke Clinic, everything goes so smoothly and everything. Yeah, but that's after years and years of really figuring this stuff out. And the problem is we just can't teach all that stuff to you. You have to figure out your own way and figure out your own path, which is the really cool part about plastic surgery. I mean, I think about like people with chipping out gallbladders or stuff like that. I feel kind of sorry for them, you know, because what we do is just really so special and it's artistic. And I want you to, that's the one thought I want you to leave with it. It is artistic. And what I love about the Buncke Clinic, man, you got a bunch of real artists there. I have to show this, Rudy. This is when Rudy was invited to come to the faculty of Duke Flap course, 2011. This is Rudy's artwork. And it just blew me away. It's amazing. And to this day, I'm still blown away by this. This is incredibly creative. And obviously Rudy's artwork and his flap design, his website that people use all the time for doing flap cases are just a way of giving back. And it's a way to show that we have this artistic expression. And I certainly would be remiss if I didn't mention Greg Switchblade Nixon. I remember when you gave me the CD and I told you it's like, it's in my computer somewhere. And when I play random songs and one of your songs come up, I still think about you and smile. But you're surrounded by some incredibly talented people who happen to also be incredibly talented surgeons. So just thank you guys so much for inviting me. I definitely am taking you up on coming. I have a whole bunch of witnesses that you offered, and so it's going to happen. But Greg, Rudy, Babak, Andrew, and Walter, thank you guys so much. What you do is amazing. The Buncke Clinic is just an amazing place. It really is the birthplace of microsurgery, and just an incredible honor for me to be part of this. So thank you.
Mike, thank you so much for honestly one of the most inspiring talks that I've seen in our field. I think this, and I can definitely tell you that any resident or fellow or other surgeons in general who are going to watch this are going to be very inspired by it. So thank you so much for that.
Awesome.
Really, it's definitely one of the best talks that we've certainly had as part of this series. And that's saying a lot considering how many great talks we have had. So thank you so much for that.
You are so welcome.
I think you bring up so many great points. We can probably talk about this, for hours. But I think one of the thoughts I had when you were showing some of these cases, especially the ones that were pretty early in your career, there's always some component of fear, obviously, especially as you're kind of a younger surgeon trying to embark on something new. And the question is always, how do you deal with that fear, right? Now, I've always thought that, a healthy level of fear is always a good thing, because you kind of need to, make sure that you're, dotting your I's and crossing your T's. My question for you is, what kind of word of advice do you have, or words of advice do you have for the residents and fellows out who are going to be embarking on a practice of their own about how to deal with the fear of taking on a big project, especially as a new attending?
There's no question that your first case out of your training, and probably your 100th case out of your training, that the nerves are there, the fear of failure is there, especially in big cases, and you have to figure out how you're going to deal with that. The analogy that I would use, Buncke, is we give a lot of lectures and we do a lot of public speaking, and to stand up in front of a group of your colleagues and there's like 800 or 1,000 people, it's just so intimidating. And I can tell you, for me personally, I'm an introvert. People are shocked when they hear that. I mean, I'm totally an introvert, and it's something that you just need to learn to channel that energy and realize, first of all, yes, I have this nervous energy, but like, I'm going to take that energy now and I'm going to apply it to the case that I'm doing. And I think that, I try to imagine a time when I ever walk into a case where you don't have that little bit of excitement. I think maybe as you go further in your career, it becomes just excitement, or you feel that butterflies in your stomach, or you feel that sort of that tingling sensation, which when you're younger, you interpret as fear. You now are interpreting as, okay, let's do this. Let's get our A game on. Let's make sure we're not missing anything. We're not doing anything. And, all these things are learned things. I think that some of the most rewarding teaching experiences I've had, I think, in residents, are the ones who are just always a little afraid, because you just want to push them. It's like, okay, just go, just cut a little bit more, do a little bit more. All of those people end up being great plastic surgeons. You have that confidence to know, listen, there's some people who are just like all in, boom, and that's their style. And there's probably something that's not great about that either. But, I think just that gentle reassuring that you are no different than anybody else. You're a human being. Like, you're going to feel nervous before you present in front of the group. You're going to feel nervous before a case, but you got to focus, and you'll be able to channel that. I think we all kind of do that in our own way, whether we do it, subconsciously or just consciously.
Yeah, those are all very good points. I see that Professor Mingwei Cheng has turned his webcam on. I didn't know if he had a question or not. So Mingwei, let me know if you have a question.
It looks like he's still driving. Stop driving, yeah. Mingwei. I told you to pull over.
Yeah, I think he's parked. You're on mute right now, Mingwei. You may want to unmute yourself. There you go.
Right. Thank you so much. It's a great talk. Very inspiring. I enjoy it very much. So,
thank you,
so much amazing cases. Really appreciate it. Thank you.
And I have in my office, I have a photograph for patients to see that I actually do surgery. I have a picture of Mingwei and I sitting doing microsurgery together. Yeah. Again, mute your phone for a second. And it's a picture of us operating, and it's one of the joys of having such a small community and sharing thoughts and visiting people and being able to sit at a table with you and to do a surgical case was just amazing. And I always show the picture, and I always tell them in the middle of the case, the light started swinging, and I was like, what is going on? And they're like, oh, it's just an earthquake. And I was like, what? I'm like, no, he's like, Mike, happened all the time. We go back, it's like, now imagine doing a micro case during an earthquake. And Mingwei's like, no big deal. Give me another 11-0, no problem. So I see you every day, my brother, and love you very much.
Yeah, you are my hero. I also have same copy of the picture to get hanging in my office. I look at you every day too.
Well, I'm sorry about that.
Well, I've had the privilege of operating at Shandong as well, and fortunately, we did not have an earthquake when I was operating there. So I have to just count my blessings there.
step out of your comfort zone. I'm like, okay,
Yeah.
I'll operate in a couple of earthquakes. Okay, then we'll talk.
I have had some earthquakes here in San Francisco though,
That's true. True
but
that.
the other question, I had a couple of other questions and comments for you. I think one of the things that you mentioned and you alluded to during some of these, really challenging cases was the importance of mentorship and collaboration. Clearly, when you started your practice, especially when you were at Duke, obviously, Scott Levin was there. You mentioned Julian Pribas in the Harvard system, even beyond, your years at MGH was someone who you would kind of run things by and so on. And obviously collaboration with Yixin Zhang with the auricular flap. I think that, that is such an important point that you made, because I think really the only way to grow as a surgeon is to have mentors around. And I know that for myself, when I started practice, I think, there's always going to be that case that comes in that you just need to get people who have more experience than you to have a look at it. And having Greg and Rudy around, who are in our offices, are all right next to each other. And we always do, we have rounds and indications conference and so on. And, you actually learn a lot more as an attending than you do as a resident or a fellow. So I think those are all really, really important.
Yeah, the thing I would say is that, and I think this is a really important point. When I started at UNC, I was by myself. There literally were no other microsurgeons, and it was a desert. I mean, you were literally on an island. There was no one really to do that with. And it was a huge, huge change for me when I got to Duke. I never even realized, but like Scott was the only one doing microsurgery at the time when he brought me over. Some of the microsurgeons who were there had left. But just to have somebody to talk about and to throw cases by and stuff changed everything. And what I would say to your fellows and residents is that's on you. You have people who you could easily reach out to, and you have to build that support of people who you consider mentors. And we love hearing from you. And there's no shame in asking a question like you, because I was very much like, at Mass General, you did your second year, you're by yourself. And so I kind of knew what that was like already. And it was like a pride thing. Like, I'm going to get this done. I'm not going to ask people. And that's just stupid. It's just, there's things that there's mistakes you're going to make and things you're going to learn, but you really don't have to be by yourself. And in this day and age, with so easy to get in touch with people and send pictures and ask questions, it's shame on you if you don't, and that's part of your fellowship, is building those relationships, and part of your residency is building those relationships. And you meet people at meetings who'll come up to you, and then they don't have mentors, but they'll want to reach out to you. And I have people who send me the cases all the time, and it's like, I just want to check this, I want to run this by you. And something that's great. We actually enjoy that. We love it.
Yeah, I think those are really great points, and I think all residents and fellows who are finishing up, I think they should take this point to heart for sure, because I think it really makes you grow as a surgeon for sure. I had a kind of a comment and then a question to follow that. You have worn many hats during your career. I think we've seen that as part of this talk and as part of the introduction. That of an academician, an educator, obviously with the flap courses and with your residents and fellows, as a business leader, working with industry, for example, on new technologies, and in private practice, for example, a different hat. And so obviously you've been able to recognize opportunities when they come along. And so I was wondering if you have any thoughts or advice to young surgeons out there, as far as, I'm sure that if somebody asked you 25 years ago, what if you would be working with, an international company developing new technologies, or if you would be, a leading best case, best save at ASRM and so on, you probably wouldn't have really had an idea. So clearly you were very open to a lot of these opportunities. And so do you have any kind of thoughts or advice on how to really recognize opportunities and take advantage of them?
It's such a great question. There's so many different aspects to it. I think the best advice I think that I would give people is you need to know yourself. There's so much of he's doing that and she's doing that, and it's like you have to decide what's important to you, because maybe taking time away from practice and being like a chief medical officer of a medical device company, like maybe that's just not in your DNA, or maybe it's just not something that's interesting to you. And I couldn't have imagined, because I did that, I couldn't imagine that that's something that I would want to do. I think my biggest problem, my wife knows this really well, is that I just feel like I just get bored. I feel like I do some things for a certain number of years, and it's like, and then like I just need something else. In fact, you mentioned getting an MBA. So I was like the only 50-year-old in the MBA class going back and getting their MBA. And, you know, and a lot of people on this call have their MBAs, you included. And I think that, you know, people may say, oh, I got to get an MBA. Like, for why? Like, what is it? What is that? What is it tickling for you that you think maybe this is something that I should do? And I think because of that sort of boredom and not knowing what to do, you know, I've always kind of been on the academic track. And I was like, well, if I'm going to be a chief of plastic surgery, or if I'm going to run a hospital or do something, I'm a great surgeon. I have no experience, you know, running organizations and running things. And so I saw the MBA as a way of like, here's a great way for me to get some of that experience and then do that. And like many things, you do something and it just changes the way you look at the world. And I think you do have to have a certain self-awareness that this is something that's actually interesting. I need to explore this, or yeah, like how many more deep flaps do I need to do, and who am I doing them for at this point? And there's all these questions. And I think, you know, as you go through life, you'll be thinking about different things. I will say certainly residents and fellows at this point, you got one job: get a job and start doing cases. It is too early in your career, I think, to be worrying about these types of things, honestly. And I tell people who I've trained that spend the first 4 or 5 years just perfecting your craft and get really good at it, you know, and to sidetrack and get an MBA or sidetrack and do something, it's just gonna, I feel, this is just my personal opinion, will limit the arc of your career. And yeah, and sometimes we don't understand. When I left Duke to go into private practice, you know, people were scratching their heads, but you know something, you're not doing things for other people. You're doing them because you know you, and it's fulfilling some sort of need that you have. And I'm also have this, I'm really lucky that I never look back on things or regret things. I kind of, once I make a decision, I'm just full on. I don't ever really look back and think about it. And it can be very helpful sometimes when you're doing surgery, because once you make that cut, you can't really put it back. You know, you got to be able to keep pushing ahead and moving on. So it's probably a characteristic that a lot of us have.
Right. Well, I think those are really great points, really inspiring thoughts. And I wanted to thank you again for taking the time, especially at a late hour East Coast time, to honor us with your talk. I'm really looking forward to putting this one up, and Rudy will have it up by tomorrow. So I'll certainly
Awesome.
send you a link. And as I mentioned, we absolutely will have you here in person.
I'm
COVID
excited for
begins.
that. That's right. We will hug regardless.
Exactly.
Maybe with N95 masks on, but we will hug and we will have fun.
Excellent.
Yeah.
Thanks again, Mike.
I would extend to anybody, you know, anybody who is looking to talk or need advice or things like that, you know, you can reach out to myself, certainly, people like me, because, you know, that's what we enjoy the most, you know, and we've made a lot of mistakes along the way. And so sometimes it's nice to learn from the mistakes of others. So, but thank you again, Bobby.
Great. Thanks, Mike. Have a great night, and hope to see you soon in person.
Absolutely.
Thanks.
Thank you, Mike.
Bye.
My brother, take care.